The Communications Advisor Healthcare, who will be the moderator of this panel discussion, Mr. Brian Carvalho. A huge round of applause for him. The next panelist we have is Mr. Bharat Gera, founder, Human-Centric Healthcare Ecosystem. A huge round of applause for Mr. Bharat Gera. The next speaker joining us on stage is Dr. Sabine Kapsi, Global Strategy Lead at United Nations Emergency Response. A huge round of applause for her as well. And I now hand over this discussion to Mr. Brian Carvalho. Thank you.
Thank you. Hi, everyone. Hi. Don't worry, I won't make you play a game. But I just wanted to find out how much time do we have just so that for this session? 45 minutes? Okay, great. So I think, we've listened to various speakers sort of talk about the need for collaboration and why it's important and how to prioritize women's mental health, women's health. And I think this session, we'll try and tie those pieces together, specifically from a policy, technology, research, and customer centricity angle, because I think that's the kind of expertise that both Bharat and Dr. Kapasi bring here, right? So why don't we just, Dr. Kapasi, why don't you start off by talking about, for those of us who weren't here in the first half and those of us who weren't here in the previous sessions, what are the various dimensions of women's health that we need to look at from a holistic perspective? Because we've looked at it in, I think, silos, but, you know.
I think our illustrious previous speakers also mentioned about, women's health, but more from the tech perspective being in silos. But I think one thing we need to understand, I think Frost and Sullivan really concised it well, but just touching briefly upon it, that women's health is not just about reproductive health. It's about looking at healthcare completely differently, looking at healthcare completely differently by women. So from a women's perspective. So it's about cardiac care being looked at differently because the symptoms look different. Being autoimmune, lupus has been known, or not just lupus, even IBD or Crohn's disease has been known to be more in women than in men, but that was actually discovered quite recently in 1970s. Before that, it was always thought about something where men were affected more by some of these problems because men were the ones conducting the research, they were the ones trying to do the need assessment, identifying the problem. So I think that is going to be, now looking at it from a completely different angle is going to be very important. Cardiac care we have all spoken about, right? A lot of ancillary care we have spoken about as well. So I think that is very, very important, that we really need to look at healthcare for women now, not just reproductive care, but healthcare cohesively. And not just from a doctor's perspective, but from a research, pharma products, tech products, and even insurance and policy perspective as well. Because, talk about insurance. When insurance started a long, long time ago. But if you look at the early 1900s, women could not buy life insurance, and there was no health insurance for women at all. And for the longest time, even today, gender-based insurance packaging actually consists of 92% of the overall insurance market. And they are priced significantly higher for females. Like, for example, someone who, a 40-year-old, 40-year-plus female actually pays more for medical insurance than a 40-year-old male. Why? We really need to look at it very, very differently. So I think we have to look at it very cohesively from a structural perspective, not just from reproductive health perspective. That's going to be very important.
Got it. Thank you. Bharat, you just want to add a little bit about overall thoughts on how to look at women's health comprehensively?
Yeah, first of all, is the mic on?
Yeah. It's on now.
So, first of all, I don't think I can match the energy of the last panel. It was so incredible. Addressing women's health comprehensively, you rightly put it, Dr. Kapasi, you have to address all the ecosystem, right? She spoke about insurance, she spoke about research. I'm sure a lot of the people in the audience are already aware of it, but I will just repeat that I think in the late 1977, there was a stoppage of clinical trials on women, and only in 1990 that was corrected by trying to bring in more gender diversity. And even that did not show results till much later in the 2000s. And even then the targets were not achieved. And from 2015, the US FDA produces a report on a yearly basis to measure gender diversity. And I was just looking at the latest report. And even now, if you look at women with type 2 diabetes and the risks of cardiac and clinical trials associated with medicines which are going to improve the outcomes, only 32% were women. And here's something even more interesting. Out of those 32% women, more than 90% were white women. So if you're an Asian woman, you've not been covered by clinical research. So I think this sort of a thing brings out the importance of looking at it across the ecosystem. I don't want to sound so theoretical, so I'm going to go into a little bit of, looking at the problem from an ecosystem angle for the last session that was happening. I'm just trying to connect the dots here. So if you look at what Renita brought up beautifully in the session about women's health, I'm just quoting from the figures she gave. She said 15% couples have infertility, right? And out of that, 94% female infertility is in China and India and emerging nations. Now, I think we need to know that why is it so? Setting up more and more IVF clinics is not going to solve the problem, right? So I think we need to look at it across the ecosystem. We need to address the problems at a systemic level. And so that's something I believe should be done. But we can talk more.
We'll talk about it a little more. I'm sorry, I must stop here and give you a little bit of background on the two speakers. I think we jumped straight into the session, and I think I'd be doing an injustice to the speakers if I don't introduce them. Dr. Kapasi is an IVF specialist and a health policy governance strategy lead. She has worked in several healthcare businesses in both the public and private sectors, Leelavati Hospital, Hirandani Hospital, Fortis, Aster, D.Y. Patil, etc. She studied at Wharton, HBS, and Stern, NYU, and has advised governments in 11 states on health policy, right, including working on Obamacare. She was at the front line during the pandemic and serves on over 20 investment committees working with investors and startups evaluating various technologies in health. Bharat is the founder of the human-centric health ecosystem. He's a true pioneer in digital transformation of healthcare, and he talks about leveraging technology aligned with strategic goals, right? And he's been doing this since 1999. And he's a true advocate of human centricity in delivery of healthcare solutions, right? Great. Okay, so that's the introduction. So next question I have is, how collaborative is the Indian healthcare ecosystem on a scale of 1 to 10? Why don't we start with you? And where do you see the drawbacks?
See, I would not say that Indian healthcare system is exactly collaborative, as in, of course, there were established structures of hospitals, pharmacy, pharmaceuticals, as well as the, diagnostic centers. That was a different world that is still exists, that they have to collaborate to create what they need to. When we talk about tech, data, when we talk about health finance, insurance, that has relatively been very segregated because we don't have insurance cover, so we did not have the closing of the loop in that sense. That being said, I would also want to put out that India is today sort of an example of a classic open market, right? We have tons of small providers and tons of small, tons of small supply and tons of small demand, which is amazing and has, in the last 5 odd years, just, mushroomed the amount of innovation that can happen in this space. Though I still think that there is a huge effort that needs to be put to tie these threads together. So there needs to be a cohesive approach. What is happening is not half bad, and I think from a government perspective, now that we have such a huge focus with ABDM, and I'm sure any of the startups who is working in this space is going to be looking at the API integrations and everything. So we are trying to bring it all on the same table, though it's a start. It's a huge system, it's a start, but it's a step in the right direction.
Sorry, I want to stop you there and ask you, are there examples of collaborative ecosystems that we can borrow from, especially from the developing world, and what are some of the lessons that we can learn from a policy and ecosystem?
So I'll talk about two projects which I worked on, because there are many that have been doing amazing work. But one is the Adulidej Bhumipol program, which was in Thailand, a very close neighbor of ours.
Right.
Thailand, the king of Thailand, always had the goals, the erstwhile king, I'm sorry, always held the jurisdiction of primary health and primary education. And they brought in the WHO 8 years ago to structure their entire primary health in a way that it became extremely decentralized, right? And because it became decentralized, the delivery networks were through frontline health workers and people. And device became one of the big deals. At that time, device research was very preliminary in nature, and which is why screening became an option. And when screening became an option, then of course insurance came in as well, because that was the genesis of big data there. So it was a very cohesive system in the FLSW systems, and it worked really, really well. Of course, once he passed away, the focus shifted and things did not go in the same way as it should have. But it was not about tertiary care at all. The entire thing was a primary health system. And there is so much innovation to be had in the primary health space. Unfortunately, even today we talk a lot about tertiary care. Most of the innovation is happening in that space. But that actually eliminates, tertiary care always eliminates, especially in the global south, where, you know, the insurance percentage overall is what, 11%. So tertiary care, the way we know it in hospitals and brands, they actually eliminate more than 80% of the population to access it. And that becomes an issue. And one more example that comes to mind is the Tallinn Primary Digital Health Initiative. Now, Estonia today is one of the best digitally integrated country in the world. And whenever you guys can, please do look up the amount of integration that they have done, right? Just, they do not have a lot of hospitals, but screening care is available for everyone. So I personally believe that insurance closing the loop, especially through value-based insurance models that we are slowly stepping into right now, is going to be crucial for us to go for better health outcomes. And whoever is working in tech, please remember, outcomes is essential, right? We talk about services, but very few studies and outcomes have been done, very few data, people on trial, right? And, you know, Tata has been doing a good job. We have the head of Tata Healthcare here in the crowd today as well. But they, you know, these services need to have an outcome and a long span outcome, and that needs to be looked at. So I think that is going to be very crucial, and that's a learning that I think we should really adopt.
Yeah. Bharat, you want to talk about a general comment on Indian healthcare and how collaborative, if at all it is, and where the gaps are, and you know, some examples of what we could learn from.
So I think Dr. Kapsi already
Sorry, this mic, I don't think.
Is it good? Yeah?
Is it on?
Is it okay? Yeah. Okay. So I think Dr. Kapsi already gave some great examples of Estonia and Thailand. I happened to just recently meet one of the doctors who's been doing studies in primary care in Thailand, and he gave me the same opinion about Thailand. About India, I think the answer will come directly from the audience. If I was to ask everybody in the audience, as a patient, do you find the health system collaborative? I don't think anybody will raise their hand across the audience, because I think one person put it really well. The journey of a patient in India through the healthcare system, and all of us have experienced this, but I like the way this guy put it. He said it's Brownian motion. It is really Brownian motion. I mean, there is no orchestrator of care. In the UK, you have the primary physician, the GP. In the US, you have the primary physician, and then you have primary care in Thailand. But here, it's a free-for-all. So you can go to a specialist directly. You can walk across and get. I've had nephrologists tell me, these rich patients, some of them just land up to me, and they have absolutely no problem. But they can buy my time, and they have the contacts to come in, and they come and consult me. And it's an utter waste of time considering the number of nephrologists we have in the country. So there has to be some method in the madness. And I think that can only come when people agree to work with each other rather than compete with each other. Now, problem is we've committed ourselves to a completely consumer-driven healthcare system. It's a problem and an advantage because it's driven down costs tremendously over the years. So India is very, very cheap in all the procedures, in all the treatments. But the disadvantage is this, that it can become really, really disordered and non-coordinated care.
Got it. Yeah. So, Bharat, from a systems design perspective, because we're talking about women's health, I'm sort of zoning in, right? What are some of the fundamental missteps made in designing perhaps the framework and the tech infrastructure for women's healthcare?
Yeah, so again, the human-centric angle is going to come first.
Yeah.
And Renita already gave the answer. There are too many men in charge. I think there need to be more women in decision-making, first of all, in the systems design. With due apologies, I don't know if Surabhi is still here. Surabhi, are you there in the audience? No, she's left. But there's a lot of people from the technology world. I'm sure you all have heard about them, right? So there are these people who built the Aadhaar stack and built the UPI and so on, and now they want to build this UHI stack and bring in a lot of technology into healthcare, right? It's all male-driven. So I think the angle that needs to come in is going to come. The last panel, the women were incredibly practical about how to solve this problem, right? So we need all the qualities that Renita, I'm just repeating Renita over and over again, but I think all the qualities that she stated about women leadership, empathy, ability to work very systematically in an ordered way, follow the guidelines that, as Professor Reddy said, Dr. Srinath Reddy said, when they did the study, they did the evaluation, the women were following the guidelines much more than the men. The men were being, so I think one answer is that.
Right.
But having said that, being from the technology side myself, I think getting the data at least available, and which is the point the previous session also was making, where's the transparency? If you talk about the success rates, outcomes, there's absolutely no data. I rated 150 telemedicine apps during the pandemic because nobody else was doing it. There was no authority to do that. There was the telemedicine practice guidelines issued by the government, but there was nobody to go and check those apps and see if they were following the guidelines. So we put together a panel and evaluated these these apps. I think a proper approach to how data is handled, and in that sense, the proposal from Ayushman Bharat Digital Mission is absolutely bang on. It's a very bold, very visionary model, and completely personal health record driven, which means the power is in the hand of the patient, and the way it's structured is revolutionary. I don't think anywhere in the world you have such a patient consent driven system which is being envisioned in India. So there's a bright future ahead on that, I think.
Got it, yeah.
All I can say,
That's all.
yeah, all I can say is, Bharatji, we try, right? No, but I think what you're saying makes a lot of sense, and that is true in this. I really wanted to ask, because you talked about gaps. There are so many people who are innovating in this space. How many of you have worked with Ashas? Right? How many of you have worked with Ashas? Okay. 4 people. I think one non-profit of that. So 3 for-profit organizations. Okay, so just 2 tech startups have worked with Ashas. Now there are 10 lakh Ashas in the country, right? All of them women, and all of them working on maternal and child health as a primary directive. And yet, just 2 of you have looked into them. Now they access more than 60% of the patient market. And I'm just talking numbers, right? It's not about the paying market, but we are smart people. We can innovate. And now with the way data is being structured and the way big data looks, that is how you subsidize cost. That is how you increase access. Because now we are going to, so one more thing that the government is doing right now is building the data highways, being the data C-axis. As in, places where the health stack everyone has heard about, I believe. But there's going to be a huge data component and a data trading component into it as well. We are trying to structure it into a way that we can monetize some of this data and pass on the advantages to reduce cost of access and cost of medicine, right? But very few people I find are innovating in this space. I understand it's humongous. I understand it's daunting. But don't you think it's time that we put our substantial experience into picture to try and work into that direction?
May I answer for them?
Please.
There's no money to do that. You talk to any venture capital firm and they will tell you that we will not be able to support you if you're going to do all this public health work.
Yeah.
And that's the problem. And I think again, I'm going to say the same answer. You look at the VC boards, and I think Renita again said that 15% of the VC, less than 15% female. Yeah. Less than 15% of VC's partners are female. And I don't know, she didn't have the statistics for India, it might be worse. Yeah. Right? I think only maybe, it may be even worse. So wherever I go and see these startups pitch, and I'm on various panels, NASCOM Emerge 50 and many other panels as a jury, there's underrepresentation of women in the investment committees. And I remember the last one, I won't name it, but I was in this committee and there were startups which were addressing exactly the same problem that they were talking about, Dr. Nanta was talking about, and what they want, using artificial intelligence to increase the possibility of successful outcomes in IVF. And the investors said it is a very niche problem. But
because it's women,
right? It's not just about 50% women, right? It's also that when you see it from a women's perspective, maybe reproductive health is very important, and it's very important in terms of making advances in it. And he's saying, it's okay. IVF is not such a big deal. It's just a niche problem. So I think more women representation across the board in all these places.
I also want to talk about, Dr. Kapasi, from a policy making standpoint, right? Are there enough, clearly there aren't enough women in positions of authority. Why is that, and what can be done to address that from a policy making standpoint?
I'll go into the social sciences aspect of it.
Yeah, please
but the point of this is patriarchy is not just an Indian problem, patriarchy is a global problem. And I don't want to be the the leftist voice in the room, but if we don't cater to audience, 50% of the global population, how are we going to innovate? How are we going to grow? And being a woman in policy and coming from a science background, I have seen all the problems, almost all. Let's say, of course, there are people who have faced much more daunting challenges. But I have seen being the minority in every area, right? Especially in global policy boards, in decision-making rooms, be it finance, be it policy. And the problem, I believe, is also that, patriarchy is not just a men problem, right? I remember working with RGM VP, Rajiv Gandhi Mahila Vikas Pariyojana. It's very old non-profit organization. We did a WHO project with them in UP. Okay, and this is a very personal anecdote. So I remember that there was this one woman who tried to join an all-women's SHG. And her husband said no. She did it anyway. So she was stripped naked in front of a punch by her husband for joining an all-women's self-help group. I mean, really, this is today where, I can see a large proportion of the room being female. Is this the world we live in today? Because this was last year. This happened last year, right? So I don't really have an answer of why it's happening. I think the only thing is we really got to push forward. We really got to support each other as women. I mean, we say this many, many times that women cannot work in the same teams together. Bullshit, right? Sorry. But I think women are amazing collaborators. I think women are amazing at supporting each other. I have had the amazing women sitting here in the last panel were both my mentors at times, right? And even today, right, I can pick up the call and call up so many people out there who will be happy to share their knowledge, their experience, help me out in whichever fix I'm in. So I think that is where we need to come from, and not just from the top 1% perspective that I think almost all of us belong to. But we really need to look at the people who constitute the masses. Right? I mean, it seems such an odd statement to put in, but we really don't, right? And like because the last panel was IVF, we talk about IVF. What's the cost of IVF in India? Somewhere around 2 lakh rupees a cycle, right? How many people really can afford it? After the pandemic, the middle class starts from 10,000 rupees a month family income. That is the middle class. They are going to afford, and they do. They take out loans, right? And now, thankfully, IRDAI has made it an insurance-positive insurance plan, but included that in the insurance cover. But then how many really pay for that insurance? Anyway, the overall coverage is 12%. So, and I have, being a gynae myself and seen that space, I've seen women, being pushed to the brink for, and these are successful women, MDs of their own companies being pushed to the brink by just the problem of not being able to have a baby or even a male baby, right? So we really need to understand the problem a little more and at least start pushing our own circles, start pushing women leaders in our own circles to prominence, giving them the credit they are due. And once we do that, eventually, of course, we would hope the world to be a little more equal.
So my answer is there's two options. One is women rule the world, right? Or the women rule the world and get the men to be with them. I think that would be a great idea. So about the patriarchy thing, I think we all know sometimes it is embedded even in the women, right? It is not about a man doing it for them. So I've had conversations about diabetes recently, and I always talk to patients and their families. So I spoke to somebody whose mother had diabetes. And the statement he made about his mother's main problem was that she goes to a relative's house, and the host offers her tea with sugar, and she takes it. She doesn't refuse because the woman is not supposed to, make things difficult for other people, right? So, and then I've heard about women who've hidden their breast cancer diagnosis from their children because they don't want them to go through all this. They've suffered, but they've hidden that diagnosis and they've not even gone, they've discontinued treatment and stuff like that. I think women need to give themselves a better deal without, necessarily always saying that men are doing the wrong thing. Yeah. I think women themselves sometimes need to give. Yeah, I think so. Yeah, and that applies to men as well. I mean, men also need to give themselves a better deal at times. But about women's health specifically, I think it came out in all the conversations that there just aren't enough conversations. It is such a taboo topic to discuss, and it's especially with men. It's almost older men now. It's different, right? It's easier for me to have these conversations. Right. But I think a lot of younger men don't have these conversations, and I think it's better that all the women have these conversations with younger men as well, and that will raise everybody's awareness. And the more these conversations happen, the more awareness and more interesting innovations will come out of it.
Sure, sure. Sorry, you want to add something, or should you just ask?
Yeah, I want to add one small thing to it. So, you spoke about gaps earlier. One thing, women's health, of course, none of us are uncomfortable talking about women's health. But we talked about psychiatry and mental health approach to it, and we talked about women's health in general. One thing that is a huge gaping hole is sexual health. I mean, it might make some people in this room uncomfortable as well talking about it, but it is very important, women are at get the short end of the stick through STIs, through lack of education, through lack of access to screening, social taboos, everything. We have very little, even dialogue, let alone innovation or solutions. Right? We haven't even assessed the problem in its entirety. We were talking about the HPV vaccine. We all know HPV is an STI, right? And women are at the short end of that stick. But we are not stopping the problem in this track. We are not talking about prevention of STIs through sex education. Right? There are non-profit organizations here and there. We as doctors, we counsel patients as well in a closed room. But when we talk about community at large, why are we not normalizing just the fact that it is? And then, of course, find solutions to the problem. I think that's something we really need to start conversing about.
Great point.
Just one anecdote I want to add.
Sure.
So 6 years back, I was at this alumni get-together of my batchmates. And these women were having some conversation about their problems. And I was shooed away. And later, my wife is 5 years younger than my batchmates. And I was like, I should have listened to all that because I had to face all the problems after. So I think we should just have more of these conversations. I'm just stressing that fact. Yeah.
Okay. Let's open up the conversation. Swati?
I mean, I agree with most of the points that you've made. Also the question that why aren't investors patient in terms of women's health returns? I think it's not just about women's health. Health in general is patient investment. And given that VCs put in money, to see that there are returns, it's very difficult for founders to innovate thinking about the larger scheme, in mind. So we're also looking at how do we get some quick results and then think. So my question to you is, I believe that public health policies can actually change the way we are looking at this because it reaches masses. And I had spoken about this even in the previous panel when I asked them that unless you're a very big pharma company or you're a very big healthcare organization, for areas that Dr. Ramya and I work on, which is menopause. We spoke about IVF. I think there's a bigger taboo topic, which is sexual health, menopause, sexual health plus menopause. Nobody wants to talk about it. So how can public policy actually start educating folks? We are still stuck up in female feticides. It's a big problem, but there's a long way for a woman to live, until 90s. So I think I would really like to hear your thoughts on that. I think it'll be helpful.
So one thing is kudos for working on menopause. I can count on my fingers the number of people working there because initially people thought that, 50 ke baad women ko kya hai? Matlab, who are they? They are invisible after that. Now they are earning. Now they can pay for self-care. They can pay. So now they became a market, right? I think that is the direction. That's the right direction because policy we are far behind, and that is how policy always works. Not just in India, anywhere globally. Policy always is pushed by social consciousness and social event, right? So it will take time for the policy to occur. On the IC side of it, I sit on some and I am fairly patient. So you can hit me up for sure. But unfortunately, the last 5-7 years with the NBFC crisis, everything that happened, we basically pumped money into a lot of stuff that now, those are the problems that are coming home to roost. And we all know what's happening in that space. So I'm not going to elaborate. But the thing is, find an investor who understands your space. And second, someone who, I would suggest, comes from a Gujarati background because, revenue forward is necessary. Unfortunately, ideation stages were invested in a big way. People did not really care about revenue. I honestly am not even going to talk about valuation because that's a different topic altogether. But, the market got really unstable, confusing for 5 years. It's correcting itself. It will take some time, but you can always call me if you want help. Thank you.
Yeah.
Bharat.
Bharat, for the very interesting talks. I'm sort of connecting the dots between what you said and what also Sabine tried to say. If the venture capitalist only, like the female VC only accounts for something about 15%, which is what was said in the first session, and there is also men are not willing to pitch money in these initial startups, right, while they make the majority of it, how critical is then the role of the state really? I think somebody was just worried that, no matter how strongly we feel about our startups, ultimately at the end of it, we're only able to make a difference to some 100,000 lives, some 1 lakh lives, some 10,000 customers. And given the kind of population that India has, right, doesn't the role of the state then becomes the most critical in public health particularly? I mean, Sabine mentioned about the Asha workers and the Anganwadi workers, so the primary healthcare providers, and yet the Ayushman Bharat Digital Mission, the National Digital Health Mission, does not even call them as a stakeholder. Right? So the stakeholders are the policy companies, the tech companies, the doctors, the labs, the clinicians, the technicians. The ABDM doesn't account for grassroots Asha and Anganwadi workers, who also, by the way, I would like to add, are not workers. Those are termed as voluntary workers, right? And basically a very, very poor remuneration for the immense work that they do. Don't you think by discussing all of this in the way that we are talking about it, we are all driven by a certain very neoliberal agenda of that healthcare is our responsibility, while the state can keep taking a back step by just rolling one scheme after the other, rather than really pitching in money where the state should do, which is education and healthcare. Yeah.
So, yeah, trust me, it is a very good question, because there are rooms that this is being discussed. There are rooms where we fight back about this. And we do, right? This exact same problem that you spoke about, we have had, many, many midnight conversations with chief policy stakeholders, because we were part of the drafting of the policy itself and ruling out of it as well. And, we always said that, पहले ये शुरू कर लेते हैं, बाद में हो जाएगा. And, we feel jilted as well that it does not happen. And which is why I would suggest two things. One is, try to make sure that you don't take money from the government. Right? Don't expect that. That never ends well. Second, we are working on something right now. In fact, we will be rolling that out from end of January onwards, where we are trying to push that 3,000 rupees wala cap, because it is heartbreaking. It's heartbreaking that a Asha worker who does so much gets paid 3,000 rupees. एक coffee दो लोग पी लेंगे तो उतने में हो जाएगा वो. What's wrong with us? And plus they have no benefits, no PF, contractor status and all of that. So we are doing something right now. We should launch it by end of January. That might help a little. But eventually I think we need to consider the system also, that insurance and the data, the way we position it for better outcomes. Because, see, okay, I come from a health, finance, tech background, which is a little, out there. So, अगर आप देखें, insurance is the only stakeholder which is financially motivated for better health outcomes, right? Try to work with them. I mean, of course, we don't have as much insurtech innovation. There are countries where there's better, but we are pushing the bill there as well. Try to work with them and try to make solutions where you don't need anything from the government. Though I'm not saying you shouldn't hold them accountable, please do. Right? We need people to hold them accountable so that we also can push the bill a little bit. But don't depend on that as the final answer, because that, as I said, is a mammoth. It will take time. Sometimes it really wouldn't go your way, and sometimes it is what it is, kind of a situation.
I'm allowed to respond, right? So what I've learned from my interactions with Public Health Foundation of India and other people working with the Asha workers, one of the things I've heard is, we've been putting, besides the low salary we're giving them, every time this new technology thing comes, we give them one more thing to carry onto the field. We are making their life very, very difficult. So, yeah. So I think too many people have gone that route that, let's try and do everything through the Asha workers without thinking about the Asha worker. So we really need to think about the Asha worker first. And I would still say this, I don't want to take a political view on it, but I think entrepreneurial ecosystem produces very good people as well. Like We've seen in cancer, we've seen in menopause, and, in many other areas. I believe a lot of them are on the right path, but I think the way the startups are engaging with the healthcare providers, as the last panel spoke about, they're not engaging with them through a platform. They're doing it one-on-one, and sitting on the other side when I'm on the hospital buying side, it's very difficult to deal with these startups because there are too many. For every doctor, every healthcare provider sees too many of these apps, so we should figure out how to work through a platform.
But is that actually practical, Bharat? Which country in the world consolidates startups? Are there examples that we can sort of learn from?
It's happening in the US. Panda Care is a startup which is aggregating digital health startups in the US. I think General Atlantic, one of the healthcare systems, is now building a platform for all of them. So they realize the same problem. They have some, I think, CB Insights rated some 18,000 digital health apps to arrive at CB Insights 150. So there are just too many apps there. So they are trying to do, healthcare systems have realized that, insurance companies have realized that. So they are asking everybody to work through a platform. Right. And big tech has these platforms coming up. So Google has this platform coming up, Apple has this platform, and Amazon has this platform. So you will see them also playing a big role coming in the future. GE and Philips, of course. Yeah.
And I think it's a bad idea. I think it's a bad idea. We have too many platforms now. We had too many apps earlier. Now we have too many platforms. I think that, this is where the government stakeholder needs to take charge, because there needs to be regulation, as was said in the earlier panel as well, Nandita ma'am mentioned, that, the data being out there, we saw the whole, secondary COVID pandemic where it was misinformation being propagated as a pandemic. And I remember, because during the second wave, I was in India, I was consulting patients, and I used to have this fun tub, where I used to put all the arsenic tablets, that homeopathic arsenic tablets and methylene blue, right? I used to have this entire tub that was filled by the end of the day, the number of patients who came with these things. This was concentrated methylene blue, dye what are you thinking, really? So, see, that is the problem. So, and regulatory solution there, I think, is the answer, and we are doing that. UHI and the policy sandboxes are working on it. Plus, I think what we are doing in India with the ABDM integration systems, Ayushman Bharat Digital Mission, sorry, I've been working with too many abbreviations lately. So that, I think, will play a huge part, because that will add on to some of the regulatory necessities and create a not commercially motivated platform structure, and the data also that can be integrated as well as structured for outcome benefits, not just for commercial benefits. I think that is the problem with the US economy as well, that even health, and I have had these talks at the HIH as well, that the healthcare system also is a commercial system. And I think to some degree regulations are necessary, not just the federal bottom line that exists there. So I think that is where I come from. I think one of the systems that have done it well, in my opinion, is the Netherlands. Secondly, even New Zealand has come up with some really amazing answer, though of course both of them much, much smaller than our systems. But I think, we definitely should learn a bit from these places.
One last question.
Yeah, so I don't have a question, but since this is the collaborative healthcare ecosystem discussion and you mentioned nephrology, so we are the renal project. We democratize dialysis and make it available to the Grameen India, the Bharat story. There are only 1,900 or less than that nephrologists all over India, and there are only 90 seats. So even if the number of nephrologists have to double, it'll take 2 decades. So in this scenario, what we have done, the renal project and me as a founder, is we do not hog nephrologists. We do not put nephrologists on our panel with retainerships and things like that. Our nephrologists and the nephrologists that we collaborate with, they are free to serve any other hospitals, big hospitals, even our competitors. There are no competitors, it's all coexistence, because the problem is so huge. So they are free to work with any other company and things like that. In fact, that has costed us sometimes credibility because the patient and their family thinks that, oh, you don't have a nephrologist in panel. I'm like, no, there's a conscious decision why we don't do it. And they feel that, oh, okay, fine. Sometimes we even lose patients.
Sorry, can we just cut to the chase and get to the point?
Right. Cutting to the chase is that when there is limited number of resources, for example, the doctors, the number of doctors versus patients, this ratio is ridiculous in India. We as a company, as a startup, have maintained that conscious decision that we will use them as judiciously and help the ecosystem in a collaborative fashion rather than, trying to build a brand value out of it.
Great.
Yeah, I think that makes perfect sense. Using technicians, using all kinds of healthcare workers to shift left the jobs that were supposedly only possible through experts. It's happened in all other fields. It will happen in medicine as well. It should very much be possible with better technology and better oversight. So what you're doing is in the right direction, but you will be in a little bit, what do they say? In the risk zone, right? You're kind of taking a little bit beyond the legal, kind of barely legal kind of stuff, right? So you'll have to face the barely legal dilemma a little bit, but it's the right way to go. If you do it right, it's fantastic.
And that opens a question to the upskilling side of it. We really need to focus on that also. And I think that's a great place to innovate. CDSS systems are a great place to innovate. We desperately need it because we all know, all of you have worked with doctors, they don't understand technology, right? So might as well invent ways to teach them that in an innovative fashion. So I think that is a big place, big gap that we really need to work on with, start from the scratch with medical students and then go up. Maybe by that time they will be way more adaptive and way more compliant to technology. So I think you really should look at that as well from a tech perspective.
Great. Thank you, Bharat and Dr. Kapasi. Thank you so much. I think you highlighted some interesting opportunities that perhaps people in the audience may not have thought about. So thank you for sharing. And of course, Bharat, you were able to highlight things that venture builders need to look out for from a policy integration standpoint. So thank you very much.
Thank you, Brian, and thank you, Anu and Praveen, and this wonderful audience. I think I've attended many conferences, but this has been a very intimate and very communicative group. It's a small group. It's been fantastic being here. Thank you so much.
Thank you so much.